The views expressed on this podcast are those of its host and its host alone. The purpose of this podcast is for education and entertainment and not to diagnose or treat any health condition whatsoever. Please talk to your doctor if you have any concerns about your health.
Welcome to Crash Cart. This is a well-perfused production.
Welcome back to another exciting episode of Lipidology Madness. We are happy to be here again with our burgeoning lipidology expert, Nisar Gray. Nisar, to have you here.
Thank you so much for having me again. Excited to have our discussion further.
Now, when we last left off, we were getting pretty deep into the world of lipidology, and we were going to talk about this thing called Lp(a). What is that?
That's a good starting question. What is Lp(a)? So, it's been a while since we took step one, so I think a small recap would be nice enough. As the basics, there are like 6 cholesterol triglycerides carrying particles, namely like VLDL, IDL, HDL, LDL, and chylomicrons. And Lp(a) is also one of those particles. It's more similar to LDL. It's one of the apoB containing particles as well. The only different thing is that it has a separating antigen on it called the lipoprotein A. Basically, it's a glycoprotein covalently bonded to the apoB particle, which gives it a slightly different appearance. And that's why it's also classified differently and gives you different functions of it as well.
Thank you so much for the biochemical and physiological importance of lipoprotein. But what I was curious about is, how do I integrate this into my clinical practice?
Right. So just to get back briefly to the Lp(a) particle, how is it different than LDL? Is that it is also atherogenic. It causes, as I mentioned, it's like an LDL particle, so it carries the oxidized phospholipids, which leads to more atherogenic developments, like plaque developments. But additional to that, because of the Lp(a), the glycoprotein, as I mentioned, it has some homologous appearance to plasminogen, so it gives it more prothrombotic characteristics as well. So that's also one of the things that gives it more risks to this particle. So as you're coming to the clinical aspect of it, Lp(a) is Lp(a) is kind of your like genetic cholesterol fingerprint. It's passed on from your parents. It's hereditary, and it's somewhat similar to having the strong family history. It's an independent risk factor. The current guidelines from NLA, National Lipid Association 2024, and the other European guidelines, they suggest or they recommend we test for Lp(a) at least once in a lifetime, so in adulthood. Basically, part of your annual preventative health screening. It's what's recommended. The AHA ACC guidelines from 2018 do have like selective high risk based screening, but I think it needs some updates and it's due for it as well based on the recent RCTs we have.
So, quick question. It sounds like, at least from what I've read in prior ESC guidelines, they initially had only high risk populations being screened, and then, as you said, more recently, now it's once in a lifetime is what's recommended. So I guess my question is this: if this Lp(a) value is stable over time, it's genetically predisposed, then is the goal to potentially reduce Lp(a), or rather is it more so, okay, this gives me a tip that the patient in front of me may be at higher risk of cardiovascular disease, and therefore it may change how aggressively I manage LDL as the marker or their risk factors?
Now, we don't have randomized control trials as of yet for lowering Lp(a), although there are some drugs on the horizon that are looking to do that. However, I think we have enough epidemiologic data to suggest that Lp(a) is causal. Like we talked about in the last podcast, why don't we just push everyone's LDL as close to zero as possible? Well, it's a question of who is actually prone to developing plaque or not at a given level of LDL. And I think we have enough information that if you have somebody who has an elevated Lp(a) genetically, they are at greater risk of laying down more plaque at younger ages at lower levels of LDL than a similar person who has a normal or negative LP little a.
It's almost as if back to our basics of genetics, everyone's phenotype is different. So it almost sounds as if the presence of LP little a for a given concentration of LDL in someone's blood may result in a patient that is more or less atherogenic and based off their predisposition.
I don't think we have like a clear answer about this, but just makes me curious, like how early we should be testing, because right now guidelines just say once in a lifetime. But when is that once in a lifetime? Should I be like checking this in like maybe 15-year-olds as they're growing up, so I could tell them that they are at high risk and they might need to consider getting started on statin and other lipid lowering therapies early? Or would this be sometime around like age 65 when people are like starting to like think about their cardiac health and like the adverse events that could follow?
In fact, I might even say after APGAR scores, I want to know the LP little a.
This in all seriousness, I think this is a never-ending question that may be very difficult to answer, because we do have genetic studies in the phenotype of folks who, for which PCSK9 inhibitors were based upon, people who just naturally have extremely low levels of LDL throughout the lifespan. They also have very low rates of MI and stroke, right? So you have this kind of genetic basis for it, but we just don't have enough information to say we should start how X young. We're kind of limited more towards the middle age, with the exception of very high risk phenotypes at the young ages.
Right. Just to touch up on the topic as well. I was listening to another podcast as well. It's regarding lipid insights from NLA, and I heard about there was a 30 resident who did like a small study at Yale. It was a very small study, about 37 patients. Since he was med peds, he was curious about this idea, how early to test for the LP(a). And the current guidelines, what we have, doesn't tell much about people, pediatric patients less than 18. So they did this study in the clinic. They tested 37 patients randomly. They did prior screening regarding if they met the selective criteria of LPA screening in pediatric patients versus not. And the outcome was that basically none of the pediatric patients who met those screening guidelines, they tested the LPA, and it met the global prevalence of which is 20%, like 1 in 5 patients who tested positive. So it was true even in the pediatric patients. And they went back and did the cascade screening, what the normal management is. And that was true again. They found 1 in 5 patients, again, had a high elevated LP(a), even though they didn't meet the selective criteria for the LP(a) screening in the pediatric patients. So I think that's a really good question from Krunal, that how early should we be testing for LP(a). The one thing I was thinking about was like, at what point in the pediatric patient's life does the LP(a) levels stabilize, and after which it becomes constant? And I'm not sure about the answer for that.
The world may never know. Now, tell me a little bit about apoB. Is this the same as LP(a), or how should we be using that?
Right. So as we touched upon in the beginning, all the LDL carrying, just to correct myself, all the triglycerides of the cholesterol carrying particles, namely like chylomicron, VLDL, IDL, LDL, are apoB particles. The apoB is basically a structural protein present in the membrane of those particles. So apoB calculation, the lab you order, it will give you basically the number of particles carrying apoB. And there are different kinds of apoB depending on which particle it's carrying as well. So the one analogy I really liked that I read somewhere was basically you can think about them as cars, different size of cars, because different sizes of particles like chylomicron, VLDL, IDL, and LDL, and they have different license plates. So apoB is kind of a license plate among those different sizes of vehicles that's carrying those atherogenic particles. apoB has been obviously correlated with the level of cardiac disease you can have, like a atherogenic disease you can have, like a plaque buildup. So apoB gives you an insight about how much of those particles are going around in your body. And this lab is actually more helpful when you have like a high triglyceride levels, or you have like a disconcordance between like a person having low LDL and still having those recurrent cardiac events, or like even a primary cardiac event with low LDL levels. So at that time, I think I would treat it going with the apoB levels.
So it's
Yeah.
almost as if, to use your car analogy, for folks who have a disproportional amount of cars on the road that have a license plate that read apoB, those cars are ramming themselves into the side of the road and depositing themselves into the barriers more frequently than those who have less of those cars on the road.
I think that suits perfect with the analogy.
Man, Fez must be driving a lot of apoB cars. Okay, then we're left with kind of one other way that we can kind of risk stratify people outside of the normal ASCVD risk factors. Now, what about calcium scoring? I hear a lot about this.
So at least from my cursory glance at most recent ESC guidelines, essentially, while they acknowledge that you have a constant value of LPA, that is where they say, okay, for your intermediate risk patients, a combination of your LP(a) value in addition to your calcium score may help us clarify some of that gray area on the intermediate risk patients. Who do I start earlier on a statin, for example, than others? At what point for an intermediate risk patient would I be okay with a moderate dose versus high intensity dose statin, for example?
And from my understanding, like if you have a coronary calcium score, that means you have some evidence of coronary artery disease. Is that correct?
That sounds correct. And in fact, in a way, you could say, if I understand LP(a) appropriately, between LPA and your calcium score, LPA has some value in predisposition prediction, whereas calcium score, as you mentioned, is, well, this is after the fact. We know now, we have evidence of not only lipid deposition, but calcification.
Yeah, and I think that's a great point. And there's also risk scores that you can use to incorporate, including the ASCVD risk score, but also adding in apoB as a risk factor, also adding in your calcium score as a risk factor. And you'll have patients who say all the time, well, doc, my calcium score is low, then I must be at low risk. I'm not going to have a heart attack. And I don't think that's necessarily the case. There is a negative predictive value to a calcium score. However, as soon as there is any calcium there at all, that only shows you that you have developed some mature plaque. Mature plaque that has been there for a long time, has fibrosed over, and has calcified. It doesn't tell you about the immature plaque that may be ripe for rupture that ultimately causes STEMI and NSTEMI. What I often tell people and patients is plaque on the inside of an artery is almost like a pimple. And your immature plaques are like your pus-filled whitehead pimples that people are just begging to pop. Those are the ones that are ripe for rupture. Now, acne that's been there for a long time and has been picked at and is scarred over, there's really nothing to pop there. It's just kind of hard and tough and scarred over, and that's kind of your calcified plaque. And really, your coronary calcium scan is only telling you about those older pimples, those older plaques.
Man, for a second, I thought this was a derm podcast. Holy moly.
Oh,
Great
don't let any
example, though.
dermatologist get a hold of this.
Thanks for the great analogies, Noah and Fez. So I just had a question for Nisarg. If I send off someone for like LPA testing and their labs come back, what numbers should I be concerned about?
So LP(a) has multiple assays. The most recent we are following is the particle number based, the nanomoles per liter. In the past, we've been using like milligram per deciliter. But as I mentioned about the car and the particle analogy, I think people are more leaning towards the nanomoles per liter. So the cutoff, I think what I've seen in the guidelines so far is like greater than 125. nanomoles per liter or greater than 50 milligrams per deciliter, given that those are not interchangeable, is considered high risk. Less than 30 milligrams per deciliter or less than 75 nanomoles per liter is normal. And between that, it's a gray area where we need to do more of a intermediate risk discussion, possibly because we can also do calcium coronary artery calcium scores to further risk stratify the patients as well, calculate the ASCVD, consider apoB levels in those patients to further risk stratify them. Given for the elevated Lp(a) levels, I think as we touched upon in the interim, was that we can pursue earlier or higher level of statin dose, Zetia, or earlier even PCSK9 inhibitors in those patients, which has shown good outcomes in the past.
No, that's what I was getting to as well. So I think all this testing, like Lp(a) or apoB, this is to get people started, or at least risk stratify them for lipid lowering therapies. But let's say I already based on the history, based on their comorbidities, I already know this person likely has high risk for coronary artery disease and adverse cardiac outcomes down the road. So I should start them on statin. In that case, could I just skip the Lp(a) and apoB and just start them on a statin?
Yeah, I think so. If they're already risk stratified and if it's a kind of a secondary prevention as you're leaning towards, yes, I would definitely skip ahead and start with the statin. Lp(a) would only help us further risk stratify them, even if they're at an elevated risk and if they want to target for even lower LDL goal.
So at the end of the day, these are just tools for people who are sort of in that intermediate range, who are on the fence of getting started on lipid lowering therapies and just want more data from their PCP before they get started on any of those things.
Correct. Yes. As if you can lean towards primary prevention as well, Lp(a) helps in that terms as well. If you want to get started on the statin levels, if their LDL levels are already low, and if they want further risk stratification, another set of example would be as a part of cascade screening, if their family members, first relatives, had a primary event, Lp(a) screening in the first degree relative would be of importance as well.
Yeah, I think that's the greatest utility, definitely in patients who are a little bit statin hesitant. I've done some of these additional measures to really help them see their true level of risk of cardiovascular events. But even more than that, it's a lot of times it's younger patients who might fall just outside of the age of screening for the pooled cohort equation or the ASCVD risk score, but have family histories that are so strong, parents and primary relatives who have had MIs in their 40s, where, hey, maybe starting therapy earlier may prevent these outcomes in their relative.
Completely agree, yes.
All right, that's about all I have for Lipidology Madness. Anyone else have anything?
Nope.
All right, looks like the folks are going to have to tune in next time for another exciting episode of Crash Cart.